Hi, I'm Tracy Larson, the Pediatric Trauma Program Manager at Regions Hospital, your Level 1 Pediatric Trauma Center. Did you know that pediatric trauma is the #1 cause of death in children? Today we're going to discuss mechanisms of injury and the expected injury patterns in pediatric trauma patients by using a case presentation. Let's start with motor vehicle crashes. What's very important for hospital providers to know is the type of crash. In a T-bone type crash, we expect to see some devastating head injuries. We expect to see rib fractures and potentially a pneumothorax on the site of impact as well as a pelvic injury. Let's start with MVCs. Very important information for EMS providers to provide to hospitals are the type of crash. A T-bone crash, we see devastating head injuries, rib fractures, and pelvic injuries. On a head-on collision, we can see restraint-related injuries in children that are not restrained properly. And in rollovers, if the car seat is not restrained properly into the car, that car seat can be ejected out of the car. Was there prolonged extrication? Did this delay resuscitation, or is your person going to come in hypothermic? Let's look specifically at restraint-related injuries. When we know that the child is coming in with a seatbelt sign, which is what you see on your screen, we can expect some of the following. Potentially a solid organ injury, which could be your spleen or your liver, potentially a small bowel injury, or lower spinal injuries. Let's take a look at a case presentation with a Ford Explorer, a tanker, and a Buick LeSabre. Here is the Ford Explorer. Unfortunately, these occupants were not restrained and they were ejected, and it was a fatal crash. Here's the tanker, and here's the Buick LeSabre, and this is a head-on collision. Driving in the Buick LeSabre was a mom and her 2 children. Her 2 children were in the back seat of the car. A 3-year-old was found unconscious, a 4-year-old was found semi-conscious. Who's your priority? They took the 3-year-old first. The report was the 3-year-old was unconscious, found slumped over in a booster seat with only a lap belt. Initial GCS was 6. Contusions were noted specifically over across the abdomen and pelvis. This patient was very unstable and had a helicopter intercept prior to coming to Regions Hospital. The patient arrived to Regions hypotensive despite EMS efforts to give fluids. We activated the massive transfusion policy because with that seatbelt sign and with that hypotensive patient, we knew that the patient was bleeding. The patient was taken directly to the OR without further imaging and was found to have what we expected, a small bowel injury. We stabilized the patient in the PICU, and then we were able to get further imaging of CT of the head, neck, and the spines because we were worried with that seatbelt sign that he could have a lower spine injury. And as you see on the screen, if you look down, he did. Where those arrows are, that shows a unstable L4 fracture. We call that a chance fracture. He had no cord involvement, and it did require a lumbar fusion. But the patient had ongoing hypotension and bradycardia. By the time we get the patient to MRI and was able to do his spines, as you can see here, he had a high spinal cord injury at C6. That required a cervical fusion from our neurosurgery team and a halo. The child was able to spend 3 weeks in our PICU and was discharged to rehab, where he spent another 4 months prior to going home. I have to say kudos to the EMS agencies. There were several involved, and they got the right patient to the right hospital at the right time. Because we are a Level 1 Pediatric Trauma Center, we are required to have pediatric subspecialties, and we have the bonus of having the rehab right on our facility. And just know that we can take care of the entire family. So remember to be aware of certain injury patterns that can follow certain mechanisms. And getting these injured pediatric kids to the right Level 1 Pediatric Trauma Center will improve outcomes. Thank you.